when necessary, particularly when we're eating or drinking. So it's the real function of the larynx is to protect the to protect our trachea. And of course, obviously, the other wonderful function of the larynx is to be able to speak. And that takes place with these wonderful structures here called vocal folds. Once again, they come together in the midline, and then a column of air that comes up from our lung causes them to go into vibration. And as the air column comes up and these cords are together, there's that Bernoulli principle that after the air comes through, there's a reduction in pressure below the cords, and they then vibrate. And this vibratory activity creates the sound necessary. And these vocal cords, they just look rather dull structures there, but they're remarkable. They have a coating over them of just mucosa, and below that there's a little tiny space, and believe it or not, in that space is a little bit of gelatin material, and that's what propagates this wave across this vocal edge that enhances the sound that we make. And then below that is this very strong muscle called the thyroid or retinoid muscle. So this is a very good example of beautiful larynx. Once again, always remember that the level above the larynx is called the supraglottic area. And the area right here is the glottic area, and then the area below is the subglottic area. So an example, epiglottitis would be a supraglottic disturbance, whereas a growth on the cord would be a glottic disturbance, or something below the cord in this area here would be subglottic, such as maybe there was an injury that affected some of the trachea or the cricoid cartilages. Well, let's go on. Now, once again, as we talk, I think we may have mentioned this, when we speak, our cords come together, and that column of air causes them to undergo vibration, and then the negative pressure continues this process of vibrating. And this is a good example of what happens when we drink or eat. Our cords are closed, so we don't aspirate. And any number of things that happen as we get older, of those individuals who are elderly, who are in a nursing home, who end up aspirating at aspiration pneumonia. They just don't have enough competent closure of their vocal cords to prevent aspiration, which is deadly for older individuals. This area here is called the piriform sinus. This is the area that opens up into the esophagus, some of that we reviewed the last time. Yes, we did, because I showed what happens as we get older. We don't have enough closing power generated by the muscle and its vocal ligament and vocal cover to cause this to be tight enough to have that column of air vibrate. So there are people who have voice changes as they get older, particularly at the end of the day. If they've been using their voice throughout the day, these muscles get weaker and weaker. So someone who's elderly might have a fair voice in the morning, but by 9 o'clock at night, you can predict that there'll be a certain weakness. They just don't have a strong voice. It's intelligible, and you can understand the words they're saying, but it doesn't have much in the way of any loud quality to it, so that it's easily heard. And they're aware of that themselves. If you spend all day shouting, you can end up with significant trauma to the vocal cords as they come together and they're put into sort of a violent vibration. If you're excessively forceful, you'll end up with blood underneath the mucosa, so this little area of hemorrhage. And that can happen it can happen on both sides. It probably happened to a few people as they watched the Creighton-Gonzaga game.
Mm-hmm.
And the amount of force depends on sometimes the individual's personality. If there are people that shout a great deal, some people are just very rough with their voice, and then they get into a situation. It doesn't necessarily have to be a sporting incident. They can just get into an argument with people and really forcefully cause this trauma to occur, and then you can end up with this lariat hemorrhage. If that occurs, they're going to come to see you with a hoarse voice. How long does it take hemorrhage to go away? Well, it has to resolve, and it sometimes takes up to a couple of weeks for it to completely go away, because it has to absorb through the lymphatics that are here, which are not very plentiful at all. Slowly, it's absorbed by this by the tissue, and then of course it'll resolve. Now here's a bit more of an area of hemorrhage. Now, obviously, this individual would be hoarse, and then you'd have to tie it together with what happened. Was your voice forcefully used, or did you have a significant period of violent coughing? People who cough violently can end up with hemorrhage. Underneath this nice vocal cover, and then into that space, there's a little space there that we mentioned a moment ago that has a little bit of gelatin-like material in it, and that can fill in, and this can occur. The other thing to always remember is that the larynx is external, so it can be injured. So someone who has a bit of trauma to the larynx, let's say they get into an argument on Saturday night when they've had too much to eat and drink and there's force, then you can end up with this hemorrhage that can be traumatic in nature, and it can significantly reduce this very critical area here. So the area from this point forward is occluded, so this individual is breathing through this sort of posterior glottic space. And fortunately, in this day and age of restraints in automobiles, we don't have a lot of direct trauma, at least in automobile accidents, to the larynx. But it can still happen in these nasty altercations where people are struck violently, because the larynx is cartilaginous in nature. It can be fractured. These individuals obviously are hoarse immediately, but the real question is, are they going to lose their airway? Fortunately, if they're wise enough to get to an emergency room, to have someone review the history and try to establish what's happening, because this can progress to the point where the larynx can be occluded. And there are people who come to the emergency room after a major injury, if they're not alert enough to have these individuals intubated, or at least supported very carefully until they can establish the degree of closure of the larynx. It can be devastating, absolutely devastating. So trauma to the larynx isn't just always innocent. It can cause enough hemorrhage to occlude the critical space that you need to breathe with. Now, I showed this picture for the following reason. You get a little glimpse of the vocal cords, and then you see a little bit of mucosal irritation here. And you see a little bit of mucosal irritation here and back here. It's a reminder that whenever anyone undergoes a general anesthetic, particularly if they have to have an endotracheal tube placed into the area of, through the vocal cords into the trachea, that can be a traumatic experience. Intubating someone, even under the most ideal conditions, can be traumatic. Now, in this day and age, they have these glide scopes. You've probably seen them. They have a way of taking a picture as they use their laryngoscope to see where the opening is in the cords. That helps immensely. They also have these LMA tubes that they can place over the top of the larynx to act to assist with ventilation. They don't all have to be tubed. But if repeated trauma is directed to the larynx at the time of intubation repeatedly, particularly if there's people that are short, overweight, short necks, severe arthritis of the neck, it sometimes can be difficult to intubate these people, particularly if they need that for this surgical procedure they're going to undergo. It can be a bit dicey. Anytime someone exposes the larynx, I don't care how careful they are, they can disturb the mucosa. So if you can imagine, if this is done repeatedly and there's a lot of hemorrhage, and then they can't see the larynx, it can be catastrophic for an elective surgical procedure. Always be mindful of that. I have great respect for people who have to administer the anesthetic. I've had a rule in all the years I did surgery. I was always in the room when they were intubating a patient, and I'll let them try to intubate it 3 times, and after that they have to stop. And you might say, well, why? I just don't like them down there 3 times with metal. I'll try the final time, and if I can't do it, we close the case. Because if you have enough edema here, you're not going to be able to even use a mask to oxygenate these people. So it's not without a risk. I don't mean to make this overly dramatic, but intubating people can be as easy as apple pie, but it can be traumatic. And you don't want a lot of trauma to the larynx. This is just an example of what happens to the mucosa as we abuse it with tobacco and alcohol. This slide doesn't do it justice, but the fullness of mucosa throughout here is disturbed with this constant irritant. Always remember, anything that you drink goes across your vocal cords. So if you drink a considerable amount of alcohol, it touches all these structures here, and of course tobacco as well has a direct effect on this mucosa. This is just a little incidental mucosal cyst that's of not significance. This is the base of the epiglottis. These are these airy epiglottic folds. But now this individual might have an element of hoarseness because they lose some of this beautiful mucosal, what we call vocal cover here, because it begins to become somewhat atrophic in nature with constant use of tobacco and alcohol. So their voice might be a bit husky, but unless you look at the larynx, you don't know if it could be something more than that. Now, we talked briefly about this. I think this would be your sister. These are vocal nodules. This is the point of maximum vibration. This is an endotracheal tube that was in place when the photograph was taken. This is a point of maximum vibration. So people who use their voice in whether they're entertainers or whatever their activity they undergo with their larynx is forceful, this point ends up with a little rough mucosal cover on each side, so the closure isn't perfect, so they sound a bit husky, and they're able to talk. Their voice is husky. They have no trouble controlling any worry about aspiration, but they have this persistent husky voice, and then usually from the history you can determine that they're not using their voice real properly. And the only way to solve that is with changing vocal patterns, so that this amount of trauma directed at this point will lessen, and then they'll essentially clear up. But if they don't, then they'll continue, and it's not something that goes away overnight. This is an example of a couple large, what we call vocal nodules here and there as well. And you can see how this would get into the way of closure in terms of having a perfect voice. I think we spoke last week about whether they should ever be removed. Well, if you don't change your vocal pattern, you can remove that very precisely with a laser. But if your vocal pattern is abusive, it's going to come back again. It will return. I may have mentioned this last time. My very simplistic rule is for children that are 9, 10, 11 years old that have a husky voice and they're screaming and hollering all recess time and after school. Can you do anything for those kids as far as speech therapy? My answer is no. They have to outgrow that. They have to learn as they get older and they're teenagers, they stop this vocal pattern of abuse, and these will, if they have vocal nodules, and often they do, they'll go away. Pretty hard to instruct an individual child at the age of 11 that wants to go out and play ball and yell with speech therapy. I don't think their success rate is very good, but I wouldn't mention it to the therapist. They wouldn't agree with me, but I've seen it repeatedly, and it can be very frustrating, but it changes as they get older. Here again, not only nodules, but you see some surrounding chronic inflammation as well in this particular photograph. this is referred to as polypoid degeneration of the vocal cord edges. We spoke a bit about right underneath the vocal cover there's this little bit of gelatinous material. In individuals that smoke excessively, particularly women, year after year, we don't know the absolute pathophysiology. That gelatin-like material really accumulates along the edge, and it really interferes with the quality of their voice. It's the often in women, much more than men, they'll be, well, maybe 50, 60 years old, and they'll have a terrible, deep-sounding voice. When they answer the phone, someone thinks it's a man. Now, their voice sounds terrible, and unless you look at it, you don't know if they could have something more significant than that. This is called polypoid degeneration of this vocal cover. It is not precancerous. So technically, those individuals, if they're willing, this is a good example of where you can use the laser and you can remove that material very precisely, all the way in its full length. And if it's done, you've done this many times, you can remove this just on one side and let it heal. And then as it heals, several months later, you can do the other side. Because if you do both sides together, up here where they come together, they'll form a bit of scar tissue. And then that defeats the purpose of changing their voice. So it has to be done on 2 surgical procedures, particularly if they've also made a determination to stop smoking. And then their voice will change. It'll become much improved. It's called polypoid degeneration. It takes many years of smoking to cause this. But it is not, surprisingly, at least in this area, it's not precancerous. Now, what they may have in their lung is an entirely different story. They may have this and then have bronchogenic cancer from many years of smoking. But this of itself is not precancerous. Here you see as well, they're just in the process of wanting to use laser. See how it's just floppy tissue that can interfere with vocal activity. Now here's an you see a larynx that looks pretty good, and right here you see something. These people can have a bit of a hoarse voice, and sometimes on the side where you visually see this on your exam, they'll also have a little discomfort there. And this is referred to as a contact ulcer granuloma. The vocal cords come together in the back. If they come together repeatedly, the mucosa that's covering the arytenoid peels away and they end up with a sore there. Well, they can't rest it because they're speaking and talking, and you end up with granulation tissue there. This can happen in people who have had an endotracheal tube in place for a long period of time. Maybe they're in the intensive care and they have to be on a ventilator for an extended period of time, but they feel that they're going to be able to improve clinically, and the endotracheal tube can come out. That endotracheal tube can move around in there and can denude a bit of mucosa and end up with this contact ulcer granuloma. You also see it in people who have chronic reflux called laryngeal reflux. They have an incompetent upper esophageal sphincter. They reflux, they clear their throat a great deal, and they end up with a contact ulcer granuloma from reflux. That's not uncommon. Should they be removed? Well, not if it's related to reflux, because obviously they'll come back. But if they're rather large and they've been there from a prolonged period of, now this is an anesthetic tube used prior to removing this, but you can imagine if this tube was in place and you have to be in intensive care for a couple of weeks, the motion of that can cause an area to denude and form that granulation tissue. Sometimes they can be rather large. Now, when they're large like this, they should be removed so that the closure is more perfect and their voice is a bit better. So it's from prolonged use of an endotracheal tube or from recurrent reflux from an incompetent upper esophageal sphincter. In some people who use their voice real violently, instead of getting a patch of hemorrhage, they'll get a little bit of hemorrhage just under the edge, and then they'll form this little polyp. This is a vocal cord polyp or cyst, and they're hoarse. They may have a perfect larynx otherwise in terms of any abuse. Some of these will get somewhat pedunculated and just come off on their own. Here's one that's below the cord edges. Obviously they're not precancerous. But they're absolutely perfect to remove with a laser because you can cut precisely right. You're using magnification. You cut precisely below the cord cover and cut that right off. If there's any question, obviously you would save that piece of tissue and send it to pathology. But this is probably the perfect example of the use of the laser with laryngeal work. And the voice returns immediately in terms of the quality of their voice. Now there are little cysts that one will sometimes occasionally see. Here's a congenital cyst of this area called the ventricle. This is the false cord. This is the ventricle. This is a ventricular cyst. They're benign. Again, an ideal thing to remove with the laser in terms of opening this up and evacuating that cyst. Here's another rather large one here. These are congenital things. Not very common, but you will see them. This is a beautiful view of the epiglottis. You might say, that seems to include some of the airway. Well, you've got plenty of airway space here, so they're not in any respiratory distress, but they're certainly hoarse because of this. Here again, a cyst-like structure that is benign and certainly ideal for removal with the use of the laser. Here's an example, if you haven't seen one in a book already. This is an example of acute epiglottitis. Look at the edema of that epiglottis. You can't see the cords. You see all this inflammation. Obviously, with the awareness of acute epiglottitis or supraglottitis, and with the emergency rooms staffed the way they are, and with the availability of pediatric emergency care, these generally are not neglected. From a very simple standpoint, my rule of thumb is if you have a child that might be 3, 4, 5 years old, and they may have a terrible sore throat, and they've got a little temperature, my rule of thumb is have them drink something. If they can drink something, particularly something they like pop or something, you can almost be 98% sure they don't have this. No one, I don't care what your age, or you're going to swallow anything when you have that much edema. So if a child looks rough, terrible sore throat, they may not be stridorous yet, but they won't drink anything, you immediately have to think of the beginning of edema of the epiglottis. That should be your rule of thumb to have that child evaluated. Now if they sat there and they've got a little temperature, they're coughing and they have a sore throat and they drink half a can of Coke, they don't have supraglottitis at that time. No one swallows with this, and that's even true of adults. The only problem with adults is they have so much more space, they can tolerate a bit of this, but a child can't. And as I mentioned earlier, usually with the way emergency care is delivered, the likelihood of losing a child is still always there. But you know, fortunately, I've had the good fortune of being called at the time they're going to intubate the child, just to be sure. Most skilled people can sedate the child and support the airway by getting by this edematous structure, particularly if they're aware of it, because the cords are not involved. It's just all this supraglottic edema and tissue that's causing the problem. Once they visualize the cords, there's no problem getting a tube in place. But we're seeing less and less of these through the care that children are receiving today than many years ago. Here's an example of acute epiglottitis. You're all told about how they don't want to swallow because it's so painful. This is a good example of all that secretion. and the opening of the esophagus is right there. They will not swallow. There's been so much acute edema. You've got a little area of necrosis here. You see all the swelling. This epiglottis is just literally creating all this tissue to be edematous and painful, so they won't swallow. At least their airway, right at this particular venture in this photograph, the airway is adequate. But if you imagine that were to increase and come across that larynx, well, then you're obviously in a catastrophe.
How quickly is it steroids and antibiotics
Right,
immediately,
absolutely.
and they respond both in 12 to 24 hours probably, just...
Once you've supported the airway, they respond rather dramatically, as
Mhm.
kids often do with proper treatment They respond. I thought that was an interesting. See, they just won't swallow anything. This intense. See, to swallow, all these structures have to move in unison, and they won't. It's like having a swollen hand. Someone asks you to pick up a hammer. Well, you're not going to dare do it because all your fingers are inflamed. The same is true here with this amount of edema. Okay, Shazam. As you noticed, I was using a new age device here.
A new age device.
Thanks to this nice lady. She said, I got tired of seeing your silly finger in front of the camera. I says, you did? She says, yes, it's always, it looks like you didn't wash it, it looks crooked. So I couldn't see it.
That's exactly what
Sounds like you.
Thank you.